Thank you. So, inadequate flap reflection results in the greater tissue trauma and decreased treatment efficiency. Now about the flap retraction. Flap retraction, once the flap is reflected adequately, retraction should be passive without any force. Edge of the retractor always tapped on the bone. Tapping of the flap between retractor and bone causes tissue ischemia, leading to post-operative flap necrosis. Avoiding continuous flap retraction for a long time period. When a flap is reflected and it is retracted, surgical field should be frequently irrigated with sterile saline to keep the tissues moistened, to reduce contamination and improve visibility. Basically, for the retraction of the flap, continuous irrigation is necessary because the full thickness flap, it causes the reflection of the exposure of bone to the surrounding tissue. So it can cause the bone loss due to exposure of the bone to the surrounding tissues. So it should be kept moistened, and also it helps in to reduce the contamination, and it also helps to reduce visibility, improve visibility, because the this contaminated area, it is continuously the saliva pools in, the blood pools in, so there is difficulty in vision. Now the flap debridement. The rationale for this basic surgical procedure is same for the flap surgical procedure. Direct visualization, it directly basically helps the effectiveness of the scaling and root layering, and it allows the debridement of the granulomatous tissue from the osseous defect. And when the flap is like debrided, when the bone, underlying bone is visible, you can see the defect, clinical defect. So whenever you want to opt for the periodontal regeneration procedure, or you want to go for the bone graft procedure, you want to choose for the diabetic tissue regeneration procedure, the direct visualization helps the better selection of the materials and better visualization of the osseous defects. Now the flap repositioning. The final step location is determined by the goals of therapy and a specific periodontal surgical technique. A repositioned flap is used when a surgical access for the debridement of the root is primary goal. Used in the periodontal regeneration procedures. A tightly positioned flap. Basically, this flap is used for the elimination of pocket. You can see the reposition flap is used in the periodontal regeneration procedure because we don't want to create more further pocket, and we want the proper closure of the bone graft material and the diabetic tissue regeneration membrane with the overlying flap. So we are not going to change the position of the overlying flap in the periodontal regeneration procedure. And for the apically positioned flap, we can see that the pocket elimination procedure, because when the position of the flap is apical, you can see the pocket is eliminated. Now the flap positioning. Now the coronary position flap. Mucogingival surgery cover either root, connective tissue graft or barrier membrane. Laterally positioned flap, positioning of the flap or contiguous site for the process of increasing the width of keratinized tissue and covering of an exposed root. So what happens with the coronary advanced flap? We are basically we want to increase the width of attached gingiva, and the second intention is to cover the mucogingival defects like the recession. So we want to cover the membrane, and we also want to cover the root. So this is, we want to move the position of flap more coronary. Lateral position flap positioning can be it can be lateral to the defect. It can also help to increase the width of attached gingiva. Now the control of bleeding. Hemostasis. Hemostasis, what we understand by hemostasis means like control of bleeding in the operative site. Surgical hemostasis, it is defined as intraoperative and post-operative control of bleeding. Surgical hemostasis, it's very much essential for, and it basically is a success for the periodontal surgery. If you cannot control the bleeding, it's very difficult for the mm, it can be the chances of the secondary hemorrhage, and there can be chances of the infection also. In 1977, studies by Babb and colleagues reported blood loss in the range of 16 to 592 ml with a mean of 134 ml. So you can see that the loss of blood is very much in the case of periodontal surgery. So there can be very much causes for the intraoperative bleeding. There can be oozing for the capillaries, small arterioles within flap, and there can be opening of the nutrient channels and narrow spaces in the bone. So you can control bleeding by placing direct pressure moist gauze for 2 to 5 minutes. This is a local hemostatic agent. Basically, it's apply the pressure technique to induce the vasoconstriction in the bleeding vessels. And if the source of bleeding is a small artery, direct pressure is ineffective. Then you can ligate this small artery with a resorbable suture. Resorbable suture means we don't have to remove the suture after a period of time. It will resolve by its own. And in the case of flap and the harvest of free tissue autograft from the palate, full thickness sutures at the base of the flap in an attempt to compress the tissues against the vessels is used. What happens, like if we are going to harvest the free gingival graft from the palate, then what we have to do, we are going to elevate the full thickness suture. So we can give a suture at the base of the flap. So what happened? So it will basically compress the vessels against it. So there will be no bleeding, because you know the palate is a very vascular structure, and to control the secret of the success of mucogingival surgery is to control bleeding on the palate. Bleeding of the bone. Bleeding of the bone, you can burnish the area where the bleeding vessels oozes out. You can burnish the bone area with the mold, the elevator, or with the curate. And if these things are ineffective, you can use bone wax. It is very effective on that area. So what happens? This is the local hemostatic agents, and it is also called as bone wax. Also come in the categories of local styptic agent. So which helps in hemostasis. Now the variety of topical hemostatic agents. So first is your absorbable oxidized regenerated cellulose. Surgicel, loose woven or knitted fibrous strips. Surgicel, fibrillar in the form of cotton disc. Surgicel, new knit is a thick, denser woven fabric. What happens basically, this absorbable regenerated cellulose, you can apply dry. It basically acts as a scaffold for the platelet. So platelet comes into this area and they start aggregating and they form the clot. So what happens when the blood clot is formed and there is no bleeding. It stops bleeding in 2 to 8 minutes and it is absorbed in 7 to 14 days. But remember one thing, what happens if if it quickly loses integrity in the blood and saliva, it is bactericidal, but it is not recommended for the implantation in bone defects unless removed before flap closure. So it is not recommended in a bone defects. Now, absorbable gelatin sponge, gel form. Purified porcine skin, use dry or hydrated in saline scaffold for platelet aggregation and clot stability. Thirdly, you can use absorbable collagen. It insteads lipophilized bovine dermal collagen and cola-coat collagen plus. You can apply dry or hydrated with saline. You can moisture it with normal saline. It achieves the hemostasis within 2 to 5 minutes, and it also acts as scaffold to the platelets and this time when the clot is formed, it is stable. It is not unstable in the environment of this saliva. Now you can use the topical thrombostatic. It comes in the liquid and powder range, absorbing collagen and sponge. Ferric sulfate, Monson solution, 20% ferric subsulfate is used. It acts as an astringent and protein precipitate, sealing blood vessels and irritating to wound. Bone wax semi-synthetic, V-wax and isopropyl palmate pressed into the nutrient canal, and it forms basically a mechanical flux. Okay, these are the topical agents which we can use for the control of bleeding. Absorbable oxidized regenerated cellulose, then absorbable gelatin sponge, absorbable collagen, and topical and ferric sulfate and bone wax. So post-operative bleeding, you can directly apply pressure tag on the flap for 5 minutes. If bleeding persists, they can use the hemostatic agent. Most of the bleeding of the periodontal surgery, it can be effective and directly controlled with the help of pressure gauge. And if it is not, like if you cannot control bleeding with the pressure technique, you can use the local hemostatic agent. Now we are going to discuss about the suturing materials and techniques. What is suture? What is suture? Basically, suture is a strand of a material used to ligate blood vessels and to approximate tissues together. Property of a suture material, it should be adequate strength, it should be of low tissue irritation and reaction, it should be low capillarity, good handling and knotting properties, sterilization without deterioration in properties. What happens basically when there is bleeding? The general principles to use the suture material is basically to induce the primary healing and to make the flap edges close together and to control the hemostasis in the area of the surgical procedure and to use the blood vessels like it to stop the bleeding. So basically it should be of sufficient strength. As such, there should be no any breakdown of the suture material within the period of healing because it can cause the scarring in the tissue. And the low capillarity because low capillarity because it can cause like because of the high capillary action, it can basically can be a source of infection because suture material acts as a foreign material and it can, because of the capillary action, it can engraves the surrounding tissues and engraves the surrounding bacteria. So it again creates a problem. Good handling and knotting properties because if the knot is not properly secure, it can cause the secondary hemorrhage and sterilization is very important. Absorbable suture. So gut is the oldest known absorbable suture material. Basically, what is absorbable suture material? The suture material which we not to remove, it can be directly absorbed from the your body enzymes. It resolves the suture material within a time period. So gut is basically the best known absorbable suture material. It is derived from the sheep intestinal mucosa and bovine intestinal serosa. Gut most variable suture in tensile strength and absorbability. Organic material highly susceptible to the enzymatic degradation. Since it composed of organic material, it can be easily lysed by our body enzymes. So it is packaged in the isopropyl alcohol. It acts as a preservative, which also serves to the condition and softening. And the suture materials, basically what happens when it is exposed to the alcohol, it tends to absorb the alcohol, and by absorbing alcohol, it tends to swell. And alcohol, what happens, it can be irritating by the tissues, so it should be removed by quick rinse to saline prior to the use. Chromic gut. Plain gut tanned with the solution of chromic salts, chromium salts, prior to being spun, ground, and polished. So chromium salt basically it acts as a cross-linking agent and increase the tensile strength of the material and its resistance to absorption by the body. It may remain for a span of 80 days when implanted. Okay, so you can see that when we use the chromic gut suture material, it can be there in body for 80 days. And the chromium salts adding as a cross-linking agent, which increases the tensile strength of material. Collagen, it is a synthetic absorbable suture material. It basically the two forms are mostly widely used: polyglycolic acid and polygalactin 910. So polyglycolic acid is a basically hydrolytic acid. So whenever like what happens in the presence of heat or in the presence of catalyst, it is converted into the high molecular weight linear chain polymer. So high molecular weight linear chain polymer has sufficient strength and it can be lysed by the body enzymes also. So suture material is prepared by orienting these filaments by the means of stretching and also by braiding. So polygalactin 910, it is a copolymer of glycolide and lactide. So these two materials, when braided, are the strongest of the suture materials. So there are studies to prove the efficacy of the suture material, and they also the prove when the two materials they are braided, they are the strongest suture absorbable material. So ADV quickens dissolution when implanted, and disadvantage is difficulty in tying knot. So what happens is studies have proved the advantage of being dissoluted. जैसे आप इसको implant करते हैं, it continuously dissoluting. But what is disadvantage? There is difficulty in tying knot, and you know the secure knot is very essential for the suture material. Now, after we have discussed about the suture material, which is absorbable, we are going to discuss about the non-absorbable suture material. So, silk organic substance undergoes slow proteolysis when implanted. So, most popular suture material and braided, so it has provided excellent handling characteristics. It produces the moderate tissue response and it does not irritate the adjacent membrane. So you can see the silk material, it undergoes the proteolysis when it is implanted, and it is the most important suture material because of its handling characteristics. In 1971, Herman has found that the silk has lowest strength among all the suture materials and ranking just above the gut and collagen. In terms of knot holding properties, it ranks the lowest of all the commonly used suture materials. Therefore, 3 ties should be for each knot. So, what is the purpose of giving 3 knot in silk? Because in the terms of the knot holding ability, it is the lowest of strength of the suture material. Now come the second, nylon. It is a braided monofilament forms. In monofilament forms, it is the most popular skin suture material. And studies have also shown that if antibactericidal activity and breakdown products of nylon, adipic acid, and 1-dihexane diamine, it causes a marked reduction in the count of Staphylococcus aureus. And nylon, this is like very important. Nylon has a property of memory. When tied, the suture material tends to remember that it was originally a straight fiber and not slip and untied. So surgeons say that they tie for one knot every day so that suture material remains in the place. So what happens with the nylon? You have to give like one knot for every day ताकि वो suture material place पे रहे. Cause of stiffness, large knot is required and tendency to tear through non-recognized tissue. It is not used intraorally frequently. Seams basically it is like very stiff and this property of the memory and it causes tear to the recognized tissue. So most common it is used in the for the other medical things, but it is not used intraorally. Cotton and linen. Strength is similar to silk, and but the handling characteristics are very inferior to them. Metal, you can see the stainless steel. It can come in the form of monofilament and braided, strongest and produce the most secure knot. Metallic material undergo degradation, resulting in transfer of points from the surface of tissue. And the suture materials also possess the tissue reaction, which produces the tissue damage and increase susceptibility to infection. Now the Dacron polyester, polypropylene, polyethylene, Teflon coated or impregnated Dacron, polyester silicone coated Dacron polyester. So what happens? That is a braided suture material. Exhibit greater tensile strength and had the not holding ability. And it causes the minimal tissue reaction and its disadvantage is very expensive. So this Teflon coated Teflon polyester polypropylene impregnated Teflon polyester silicone coated polyester material. So this is like suture material and we are going to discuss about the indication of all the suture materials, which suture materials you can use in which area.